today's I was supposed to present benzodiazepine abuse in special population, but I have taken the liberty to present benzodiazepine use rather than abuse. I will also try to describe what is the guideline that has been proposed to use benzodiazepine in some of the special population, and also I will touch upon some of the abuse related thing also. So this will be the outline of my presentation. So first we'll start with children and adolescent, then pregnancy related thing, and then elderly. So as we know that benzodiazepine and other related agonist compound like the jet drugs, that is among the most widely prescribed drugs throughout the world, and alprazolam being the 10th most commonly used drug in USA, and 4 benzodiazepine drugs are among the most commonly used drug among the first 200 drugs. So because of various reasons, this benzodiazepine is used throughout the world, and at the same time misuse and abuse also can be found in all the ages and all the special populations. So use disorder, if you compare use disorder among some of the special populations like elderly, adolescent, and pregnant women, are disproportionately more having impact in this population compared to young adults or middle-aged population. So what is the reason that we'll discuss? Another important aspect of this special population is poly drug use that we'll not discuss today, but I will take this occasion to give one data that emergency department admissions and emergency department visits that has been associated with benzodiazepine are mostly associated with polydrug use, and most of the person who are admitted are having taking benzodiazepine as the second line, most of them having the primary drug of use either opioid or alcohol. So that is another topic of discussion, but we will not go into detail today. So first we'll start with children and adolescents. So as we know that anxiety disorder often begin in the childhood and adolescent in the form of social anxiety, separation anxiety, and it is the most common psychiatric disorder in this age group, and prevalence varies from 8% to 30% depending on impairment of cutoff. And anxiety disorders may be even more common in children with neurodevelopmental disorders. So very commonly this benzodiazepine, we tend to use benzodiazepine in this adolescent age group for depression, anxiety, and related psychiatric disorder. Just contrary to the evidence that it should not be used, it is not supported by any guideline. I will quote only NICE and SIGN guideline here, and one of the reason being it may lead to paroxysmal disinhibition in some of the children, but in some of the cases they mention benzodiazepine as the second or third line just to potentiate the therapeutic efficacy of some of the SSRIs, and also to mitigate the early adverse effects of SSRI, and also for rapid tranquilizations. And if we see the guidelines related to insomnia, we'll see that there is no mention of benzodiazepine as a drug of choice or any choice for insomnia in this age group. So first line of management should be sleep hygiene and behavioral intervention, followed by melatonin. Melatonin is now the first line drug for children with insomnia. So now we'll move on to the abuse or use disorder part. So this is one of the very important survey monitoring the future, MTF survey. So they actually tracking all the children and adolescent from 8th grade, 10th grade, and 12th grade since 1975. So there is, you can see in this graph, there is a steady decline of benzodiazepine use from 1975 till 1992. But from 1992, there is again a steady increase of use till 2002. Then there is a gradual plateauing, and almost for the last 1 decade, the benzodiazepine used almost remained a constant. And as you can see, in grade 8 students, it's 1.8%, in grade 10, 4.3%, and in grade 12, 5.3%. So there are some specific characteristics which is related with adolescents who used to use benzodiazepines, which is different from adult population. So most of the sedative hypnotics used by adolescents are sporadic. So it's not a continuous use. And it is associated with abuse of primary substance that we have already discussed. And in most of the adolescents, they have access to sedative hypnotics because they live with an individual, either parents or any guardian, who has been prescribed a benzodiazepine for their psychiatric disorders. And they may be less accepting of evidence of impairment associated with benzodiazepine. They may accept that I am dependent on it, I can't live without it, but they will not accept that it is actually hampering his day-to-day activity or other academic goals, all those things. And identifying withdrawal symptoms as re-emergence of their underlying anxiety and mood disorder. This is very common in this age group. So that's why it's very difficult to convince them to take off the benzodiazepine when they are dependent to it. These are some of the salient points we need to discuss while assessing the patients of benzodiazepine dependence in adolescent. Apart from taking a thorough medical history, psychiatric history, family history, recent stressor, life changes, and other educational, vocational issues, drug history, social history, some of the history relating to source of benzodiazepine. That is very, very, very important. And education about that, giving education about the source to the parents, because it is said that in most of the cases, family medicine cabinet is the most common drug dealer for these adolescents. So all the patients should need to aware of it. Another is social learning in the form of modeling is a very important part in this age group. So if there is any parents or any siblings who has this kind of drug popping habits, it may affect the adolescent children. And we also need to see about the component of any other comorbid anxiety and depressions. Because in many of the cases, they used to self-medicate themselves and used to get some immediate reliefs. That's why they used to hook to that drug. And in this population also, high-risk behavior is also very common, like high-risk sexual behavior. That's why STD workup and related workup is very much necessary. And other medical complications related to those high-risk behavior also need to be taken care of. So as we can see that it needs a multidisciplinary intervention, and along with it a prolonged intervention. So residential treatment or inpatient intensive treatment is preferred in this age group whenever we are contemplating a benzodiazepine detoxification in this age group. So we'll move on to pregnancy. So women as a whole is a vulnerable population for benzodiazepine drug abuse or dependence. Why is it so? Because they are more likely than men to suffer from depression, anxiety, and trauma and victimization, and all of these disorders are associated with various kind of substance use. Second important cause is many of the women are having harm avoidance type of temperament. So women at different ages reports using drug to cope with the stressful situations in their lives. Next important cause is significantly they are more likely than men to be prescribed medication with high abuse liability, and it not only includes sedative hypnotics, also include narcotics, and many of the physicians used to prescribe that for longer time. So these are some of the points for which women are very much vulnerable. Now, next we'll move on to some of the guidelines. And first we'll discuss about some of the teratogenic effects. So benzodiazepine not a major teratogen. So the women who are exposed to benzodiazepine in first trimester, they it is seen that in newborn oral clefts, especially cleft palates, are seen as a neurodevelopmental finding, and also along with some of the GI findings are also there, like pylorostenosis and alimentary tract atresia. But interestingly, a large Swedish cohort study has been done, and it did not confirm this evidence. Not only it confirmed this evidence, it is not showing any other kind of abnormality also. So this is a controversial thing, and the percentage of cleft palate also is 0.7%, which is almost very near to placebo. But there is a clear-cut association between benzodiazepine use in pregnancy and low birth weight and preterm delivery. And when the woman is the child, the newborn is exposed in third trimester, it is commonly associated with neonatal difficulties like floppy baby syndrome, that is diffuse hypotonia, fatigue, and eating inability to suck, and also neonatal abstinence syndrome, which is characterized by irritability, vomiting, and in some rare occasions seizures. This controversy continues in case of categorization of benzodiazepine also. According to US FDA, it is categorized as category D, but according to Australian TGA, it is categorized as category C. And not only that, some of the specific benzodiazepine like flurazepam, estazolam, temazepam, they are categorized as category X, that is not to be used in any situations. But current recommendations are that the use should be minimized as much as possible, and if benzodiazepine are absolutely needed, then it should be prescribed at lowest effective dose for the shortest possible duration, and avoid using in the first trimester, and also avoid with other pharmacotherapy. We have already discussed that anxiety disorder, insomnia, not only common in women, but the increased frequency is seen in pregnancy. And in this case, most of the guidelines used to say that preferred treatment are CBT and sleep hygiene measure. And NICE recommends that use of low dose chlorpromazine and amitriptyline, and that also for short duration of time. And there is mention in SIGN guideline about promethazine, because it is approved for hyperemesis gravidarum, so it can be used in case some of the cases of insomnia also. In IPS guideline, they have mentioned that diazepam is safe during pregnancy but not during lactation. Chlordiazepoxide is safe during pregnancy and lactation, and alprazolam they have mentioned specifically to avoid. Some of the specific issues, there is a separate directive for withdrawal, so I will not go into detail, but there seems to be no such much difference between pregnant and non-pregnant women going through withdrawal, but it can be prolonged for 3 to 5 weeks. And time course actually depends on dose of the drug, duration of the drug, and duration of the drug actions. Now, benzodiazepine withdrawal in this is likely to be seen if it's received in therapeutic dose for 4 to 6 months, but it may appear earlier also. And if it's taken in high dose, that is 2 to 3 times of the therapeutic dose, it can appear as early as 2 months. So the severity actually depends on some of the things like rapid elimination of the drug, high potent drug like lorazepam, abrupt discontinuation, high dose used, and SOS schedule is also notorious to produce withdrawal syndrome, and history of dependence and history of other drug use, like especially like alcohol, and history of anxiety spectrum disorder, especially panic attacks. This is a very interesting slide. So if we consider the withdrawal symptoms of benzodiazepine, we'll see that there are some commonalities between benzodiazepine withdrawal and pregnancy, like restlessness, insomnia, nausea, vomiting, hypertension, and increased pulse. All these things are can be seen in pregnancy. So it's at times difficult to differentiate between benzodiazepine withdrawal and the normal signs of pregnancy. But some of the signs we have to see to differentiate it, like impaired memory, distractibility, agitation, tremor, hyperpyrexia, and sweating, and especially other perceptual abnormality like hallucinations. This may help us to differentiate between these two. So I would like to mention some of the special points to manage withdrawal in pregnancy. First of all, treatment should be individualized, because the treatment will vary from the stage of pregnancy, the person's personality, educational level, and also the amount of use. And always we should taper the medicines as slow as possible, and the schedule is the safest period to taper or detoxify the patient is on second trimester, because it is having the lowest risk of spontaneous abortion and premature labor. And it is better to use the drug of use only rather than shifting to diazepam. And clonidine may be a good choice, because clonidine is, as we know, is safe during pregnancy. But some of the drawback of clonidine is that it should be started before onset of severe withdrawal. And another thing is that clonidine will not take care of withdrawal seizures. That is another drawback. Regarding breastfeeding and benzodiazepine, one index is there, which is called relative infant dose, which is calculated from the concentration of medication in milk and concentration of medication in mother's serum. So if it's less than 10%, usually it is said that it's safe to give the drug. So in case of diazepam, it's more than 10%, but in case of lorazepam, temazepam, clonazepam, which are less excreted, can be given. Clonazepam and alprazolam also has been used, but reported to have some of the side effects in infants. And so the summary is that benzodiazepine, like long half-life, like diazepam, should be avoided, and any infant exposed to benzodiazepine in breast milk should be monitored for CNS, depression, and apnea. So next we'll move on to elderly population. First, we'll discuss the prevalence. So utilization of these medications in elderly accounts almost 20 to 30% of whole prescription treatments, whereas the elderly population represent around 15% of the population. So it is this use is overrepresented in this population. And epidemiological studies also showed that 25% over 65 years of old are exposed to benzodiazepine, and especially who are living in old age home and nursing homes. Use of hypnotics was more prevalent among women than men and increased significantly with age. As you can see in the next line, that 15 to 20% among person between age group of 65 to 74, but it's more than 25% in the age group of 75 years. So with this high prevalence, it's readily, you can say that prescriptions are often in due to multiple indications and often for long periods of time. But how benzodiazepine differ in actions compared to adults? So for that, we need to discuss about pharmacokinetics and pharmacodynamic effects of benzodiazepine in elderly population. First, like absorptions. As the GI motility is decreased in old age population, so the absorption will delay, but overall absorption will remain almost the same. So the onset of action will also delay. Now, next, distribution. The distribution actually depends on some of the factors like albumin level, which is less in old age population. Next, your body fat, which is comparatively more in old age population, and body water, which is less. So as a whole, volume of distribution is high in old age population. That's why the elimination half-life will also very less. So old age population used to accumulate the drugs very easily. But in case of metabolism, without any history of liver impairment, it is unlikely that they will have a decreased metabolism. So it almost remain the same. In case of excretion, almost all the old age population more than 65 will have some mild renal impairments. So elimination also will be delayed. So as a whole, onset of action in old age population is delayed and accumulation is much more higher compared to adults. Now, if we see the pharmacodynamic properties, all of these benzodiazepine are having high blood-brain barrier permeability, especially like diazepam. But this blood-brain barrier permeability further increased in old age population. And also there is increase in hypersensitivity of receptors. So sensitivity to the effects of benzodiazepine is much more higher in this population. So due to these reasons, there is augmented adverse effects. So now first we can divide this into three categories. First of all is cognitive adverse events, which is like memory loss, confusion, disorientation, and pseudodementia-like picture. So as we have mentioned, the pseudodementia, there is one very alarming study that has been published in 2014, which matched almost 2,000 individuals, elderly individuals, and they have found that the Alzheimer's disease is actually associated with benzodiazepine use, and the association is very much stronger when it observed for long-term exposure, and this association persists even after adjusting for anxiety, depression, and insomnia. Other side effects are like psychomotor types adverse effect, dizziness, loss of balance, and also some of the morning impairments like residual morning sedation. So in this age group, there is high risk of RTA, motor vehicle accidents. All those things are common if he is taking benzodiazepine. What should we do? So I will mention just two studies which is having encouraging results. Only in IMPACT trial, we can see that only giving the educational browser and risks of taking hypnotic and sedatives along with picture of 20 weeks tapering protocol, almost 27% individual received the interventions compared to only 5% in control. Another randomized control study also suggests that the simple advice and physician-patient discussion followed by the tapering protocol enabled elderly population of 45% to reduce their dose. So during tapering, the dose of elderly, we should be cautious. It should be as slow as possible. It may take 4 to 5 months in general. Withdrawal symptom tend to be most severe during the last quarter. So we should be much more cautious during that last part of the tapering. And substitution with diazepam may be necessary in some of the cases, but should be avoided. And it is much more advised to skip the dose every 2 to 3 days. With the therapeutics, you also there is one study by Belargion who find that combination of CBT along with benzodiazepine has much more superior effect in tapering or detoxification compared to chronic benzodiazepine. Chronic benzodiazepine who have only received therapeutic help. So CBT for sleep, sleep hygiene, and psychoeducation is advised. Just 2 points about benzodiazepine in renal impairment. There is no clear-cut superiority of any agent over others. And lorazepam has been suggested by NICE guideline as the drug of choice. And in case of benzodiazepine, liver impairment, short-acting, and the drugs which don't have intermediate active metabolites like lorazepam, oxazepam, temazepam should be preferred. So we can conclude that benzodiazepine may be effective in some of the certain conditions in some of the special populations, but we should be cautious before prescribing the agents, especially in special population, and it can have a significant increase in morbidity and mortality, especially when combined with other agents. And more research works, studies are needed in special population to ascertain the actual risk and benefit. And in most of the cases, a comprehensive recovery treatment plan is needed to treat in this special population with benzodiazepine dependence. These are some of the references. Thank you.